Just not in the application. It's so cold.
No.
Across the hall, that room over there is really warm, I mean, uncomfortably warm. But this room, oh, it's cold. Oh, there's Maddie. Maddie, can you hear me all right?
Yeah.
I'm going to walk away from the computer to see if this microphone's working. You tell me if you can hear me, okay? Maddie, can you hear me?
Yeah.
That's what I'll use then.
I have hiccups so bad. I know.
You warm enough, Brooke?
It was so
Yeah, I think this is all we might have show up today. Oh, wait, a couple more customers. Natalie with her apple.
sorry about that.
You still hiccuping?
Yeah, it's gonna be rough.
there any more quizzes out? For those of you who have not been able to take the quiz today, please see Mrs. Schaefer. Come a week from this Monday and you can take them then. We have quite a bit to get to today, so this is meant to try and help you get your head around all the info. I tried to make this as brief as I could to try and give you a list of things that will be important. When it comes to diseases of the skin, there are some conditions that you're going to see more often in children than you will in adults on the average. Either because adults have already had those conditions or because the condition simply is such that adults just don't get them. Their immune system is experienced enough to not be susceptible to them. And that's kind of the long and the short of it. So I'm gonna make this. So the first things to talk about are the types of lesions. If your lesion is flat and it's up to not greater than 5 millimeters in diameter, it's a macule. A macule. And if you have a bunch of them on the body, that's a rash. So then you have a so-called macular rash. That's a lesion essentially that's less than 5 millimeters in diameter and it's flat. A papule is up to 1 centimeter in diameter and it's raised. So just run your finger across it. If you don't feel a bump, it's flat, it's a macule. If you do feel a bump and it's less than 1 millimeter in diameter, it's a papule. Rashes can be maculopapular. So we'll see some rashes can start macular, become papules, and as we'll see in the case of chickenpox, you often have spots that are at different stages in the disease because new spots are arising during the disease. So a mixture of macules and papules are maculopapular. Vesicles are essentially blisters filled with fluid. They're up to 5 millimeters in diameter. Now, if you have a fusion of those and they are bigger than 5 millimeters, they're typically called a patch. A patch. P-A-T-C-H, patch. And if those patches have, for example, silvery skin that's scaly, then it's usually called scales. So psoriasis, for example, you have scales because the skin gets a silvery look and then it starts to kind of, you get raised areas that are tucked under one another. If you brush your hand across it, it flakes off very easily, typically leaving raw skin underneath. Those are scales. So those are different. So let's look then at some of the soft skin and soft tissue infections. So superficial infections include things like impetigo. Some people say impetigo. It depends on which emphasis you put the syllable. Impetigo is usually seen in children. Rarely it's seen in adults, but it's usually seen in children. And then, of course, folliculitis. Folliculitis, as the name implies, is going to infect hair follicles. These can be superficial. Both of them will tend to cause itchiness. There's a type of folliculitis that you get if you've been in a hot tub. And it's called hot tub folliculitis. Hot tub folliculitis is caused by Pseudomonas aeruginosa. And the lesions usually are very small. They'll itch, and they're over usually a wide range of the body. And again, it's usually due to tubs that are not well chlorinated. They don't get that hot. Because some people, they'll only want their hot tub to be at, bathtub temperature, maybe low 90s, high 80s, something like that. I get a hot tub, I'm 102, 104 kind of guy myself, but some people like their hot tubs kind of tub water, so to speak. If they don't treat their water well with chemicals, Pseudomonads can grow in it. They can cause, because of the expansion of the pores and the heat, and also if you sit at a jet, the jet pounding the skin with the heat, that opens the pores, and the Pseudomonads go in, and they can cause the inflammation of the hair follicles and sebaceous glands. That's hot tub folliculitis. Very good. Let's talk now about some of these different types of infections. So a folliculitis, it can be papular, so it's raised, or it can be pustular. So a pustular lesion is going to usually have a crust on it. That's usually the result of dead cells, fluid, and what have you that have become dried and encrusted on top of the lesion. If the crust is removed, which people like to pick at lesions, I know I do. Should your patient pick at their lesion? No. Why? Yes, susceptible to superinfection. Also, that crust, that's kind of your body's natural Band-Aid. So it's protecting it from further damage due to shear forces and things like that. The skin underneath is in the process of healing. If you pick that off, you've picked the Band-Aid off. Now it's going to be susceptible to drying and also superinfection. So please encourage your patients not to pick their Band-Aids, natural Band-Aids or crusts and things like that. Also, repeated picking of chronic skin lesions increases your risk of skin cancer. Very good. So impetigo can come in two different forms usually. There is a type called bullous, and then there's non-bullous. Bullous and non-bullous impetigo. Now with bullous impetigo, the cause of bullous impetigo usually is Staphylococcus aureus. And in the case of bullous impetigo, the organism makes toxins that are called exfoliative toxins. What these exfoliative toxins do is they cleave the connections between the epidermis and the dermis. So the epidermis now will start to lift off the dermis, and it makes a little dome-shaped lesion like that. That looks like a little bulb. That's why it's called bullous impetigo. Bullous impetigo. These bullae, they rupture easily. If they do, they leave a little erosion. Most frequent areas of these are going to be on the face, on the trunk, on the extremities, or on the perineum. Now, since Staphylococcus aureus is found on the skin and can be spread among family members, it's very important to prevent this from spreading to person, that people wash their hands and they don't touch the lesions. Or if they do touch the lesions, they wash their hands right away. You can see essentially how someone can, say, a parent can touch a lesion to help bandage up a lesion on a child and then scratch their face. And then the next day, they get a lesion on their face. Well, not the next day, but the next few days. So it's very important for your patient education, if you see this in a family, to let them know this is contagious. You prevent this by not touching the lesions, covering the lesions, and then washing your hands after you've dealt with a family member who essentially has these lesions. Bullous impetigo is seen in newborns, children, and adults. If they're immunocompromised, they can develop into more severe generalized forms of disease. And the more generalized form of this disease is called staphylococcal scalding skin syndrome, which is mercifully abbreviated SSSS. Staphylococcal scalding skin syndrome. Now, those of you who work peds, especially those of you who work NICUs, you'll see this because the child will get infected, usually at the umbilicus, where the umbilical cord was cut. So the lesion usually starts at the umbilicus, and then it spreads to the body from there. But these types of lesions, here's an example of a bullous type impetigo lesion. You can see that all right, that's glary. Jenna, can you try one of the, that better? Yeah. Okay. Here's one of these raised lesions like this. Now with staphylococcal scalding skin syndrome, you get something like this, essentially. Can we agree this looks severe? And it usually is. When a baby essentially, and the good news about this is that it's just epidermal. The kid will regrow its skin and her skin, and it won't scar. Usually if you have things in the dermis, then you'll get cicatricial type of lesions, things that scar. This usually won't scar, but because this is all over the whole body, and because skin is very important to keeping moisture, dehydration is a big problem. This now becomes systemic. You need to treat this. This can't be just a local sort of thing. So in cases like this, you need prompt diagnosis. A culture is usually very useful. In this case, either something from the bullous. You can take something from the bullous, or you can take a skin snipping from the skin that's peeling off, or something like that. You can use there's lots of different media for MRSA that will grow the organism quite well. You're also going to want to get cultures from blood and urine and things like that. You want to make sure you rehydrate the patient, because water, liquid loss is going to be a big deal if your skin's peeling off, obviously. Antipyretics, such as acetaminophen, ibuprofen, can help with the pain, because I think we can agree in a case like this, baby's going to be in a good deal of pain. Very often with lots of bullous impetigo types of lesions, you're also going to have systemic symptoms, the big one being fever. Fever. If your organism is a methicillin sensitive Staph aureus, then you're going to treat with staphylococcal specific penicillins. So things like nafcillin or oxacillin. Those are available in both oral and IV formulations. Obviously, you can't really give an infant an oral formulation. They're not going to be able to swallow a pill, are they? You're going to have to use IV antibiotics in cases like that. If your organism is methicillin resistant, Staph aureus, your drug of choice is, Haley, remember? Vancomycin. Vancomycin. That's the case if it is MRSA. Vancomycin is your first drug of choice. Some people, in response to vancomycin and some other drugs too, will get a potentially life-threatening hypersensitivity reaction. This reaction is called drug reaction with eosinophilia and systemic symptoms, otherwise known as DRESS. DRESS is rare. It's not at all common. Most often the reaction begins 2 to 6 weeks after initiation of the medication. You get this skin eruption that progresses more or less rapidly into a infiltrated erythema that will involve 50% of the body surface area. Blood tests will show that the patient has eosinophilia. And they'll also have systemic symptoms like fever. They'll have enlarged lymph nodes, malaise, but then you start getting involvement of internal organs, kidneys, liver, lungs. Usually if you withdraw the offending medication, this stops usually right away. Now, what about non-bullous impetigo? Non-bullous impetigo can be caused by Staphylococcus, but it's also usually caused by group A strep. Or it's caused by a co-infection of staph and strep. So in these cases, the lesions usually develop over previously damaged skin. So for example, mosquito bites or scrapes or something like that. They start as vesicles and they'll evolve over about a week into a gold crusted plaque. A gold crusted plaque. That plaque is about 2 centimeters in diameter. Some of these are pruritic, that is, they itch. There might be enlargement of regional lymph nodes, not always. Lesions usually will affect the face and the extremities. You don't get the fluid-filled vesicles in this case. That's why it's non-bolus. For your non-bolus, usually a 7-day course of cephalexin. Cephalexin usually will treat those nicely. A alternative would be dicloxacillin. That will usually do it too. If we're looking at folliculitis, folliculitis usually can be treated with topical antibiotics. The antibiotic usually that's available that uses 1% clindamycin. If you just have a folliculitis, it's pretty superficial. If the folliculitis now starts to get deeper into the dermis, you now have a so-called furuncle. A furuncle. So now you have dermal involvement. If you have several furuncles together, close together, and especially if they fuse, then you have a carbuncle. So folliculitis, superficial. Infection of the hair follicles, superficial. Furuncle, it's further, furuncle further into the dermis. And then carbuncle, they get in their cars and they drive together. They fuse. Yes, Brie, it is dumb. Go ahead and laugh at me. And when you remember it on the NCLEX, you'll thank me. These are usually caused by Staph Coccus aureus. Usually. They can be caused by Staph epidermidis, but they're usually caused by Staph aureus. So your book mentions a lot of the virulence factors of Staphylococcus. There are many. We looked at some of these in the lab. They make lipases. They make deoxyribonucleases. They have enzymes that degrade connective tissue so they can invade. There's staphylococcal protein A on the outside that helps them escape antibody-based immunity because they bind antibodies and coat themselves with antibodies. They have coagulase that causes them to be surrounded by fibrin. That fibrin protects them. They have several different enzymes for binding to tissues. On top of that, they're just a tough little booger. They're hard to kill. So think of these guys as the Panzer tanks of infective agents. For those of you who are history buffs at all, which I know guys are a lot more into tanks and things like that than gals usually. But yes, I guess it's a little bit sexist, but that's just been my experience. It's usually guys who have toy tanks and play with them, not usually gals. So the Panzers were the big, huge armor tanks that the Germans made in World War II. They tended to be slow and plodding and extremely powerful and very hard to destroy. So these are the Panzer tanks, essentially, of skin infections, your staph. And coagulase tests will do a very good job of ferreting out whether or not you have a staph aureus. The staph aureus is coagulase positive. The other staphs are not coagulase positive. Oh, folliculitis. Another thing that works well for folliculitis is benzoyl peroxide scrubs. You can buy those benzoyl peroxide pads for scrubbing your face for acne. There's lots of commercial products that use benzoyl peroxide. That's a very good cleansing product for superficial things like folliculitis. That's another thing to recommend for people with folliculitis. For things like furuncles and carbuncles, now you're going to need probably systemic antibiotics. So cephalexin and dicloxacillin are usually your best bets for something like carbuncles and furuncles. Carbuncles sometimes might need to be drained. So that's something that some MAs are actually trained to do that. Usually the dermatologist will do that. Although some dermatologists will not do that, they'll send you to a plastic surgeon to have that done. It's common for guys, especially guys in puberty, especially athletes, because they sweat a lot, to get them on their back. And when they're big like that and they're on the back, especially guys who are really hairy, because they have more hair follicles to get infected, they can't reach them. So washing them is hard. And also they may not know they have them until one day they're just like, yeah, that hurts. I wonder what that knot is I have in my back, and it's a carbuncle. So in that case, the best thing to do might be to drain them. Don't squeeze them. Don't squeeze them. They're not a pimple. Don't squeeze them. If you squeeze them, the cells might be surrounded in the dermis. You squeeze them, you blast open that capsule, and now these cells go invade the bloodstream. So squeezing them is enemy number one bad idea. Because you get well-meaning people who say, oh, it's a pimple, squeeze, which you shouldn't squeeze pimples either, but another story. All right, now if staph invades the subcutaneous layer, the layer of fat underneath the dermis, then you have an infection called cellulitis. With cellulitis, usually you get a layer of red on the skin, but the borders are very poorly defined. Cellulitis is mostly on the extremities. It's most worrisome if you get it over the orbit of the eye. That's called periorbital cellulitis. That's a medical emergency. Bad there. That'll. Cellular or orbital cellulitis will cause pain with eye movement. The lid also starts to droop. That's called proptosis. Drooping of the lid. And then in some cases, you might start to get the vision because of the pressure on the eye. The image starts to get blurred so that you kind of see two of something because of the smearing of it. So that's called diplopia. Diplopia, D-I-P-L-O-P-I-A. big issue with cellulitis is that those cells can go deeper and they can cause things like thrombophlebitis. Rebecca, what's thrombophlebitis? Okay, pull it apart. Thrombus, a clot. Phlebitis means it's in the legs. The veins of the legs, usually small veins of the legs. If it's the bigger veins of the legs, then it's called deep vein thrombosis, DVT. The small veins in the legs, that's phlebitis. It's very painful. You get thrombophlebitis. You can also get osteomyelitis. Osteomyelitis is dastardly hard to treat because it's very hard to get drugs into the bone. Or septic arthritis. So if someone has suspected cellulitis, you treat it and you treat it right away. If it's a small patch, you can usually treat it in an outpatient fashion using cephalexin or dicloxacillin. If you have systemic signs, you have lymphadenopathy, fever, the patient is febrile, there's malaise, then usually IV oxacillin can be initiated and then with a 10-day course of oral antibiotics afterwards. If the patient looks severely ill, you start IV vancomycin. If there are abscesses, abscesses need to be surgically drained. The abscess is surrounded. Giving drugs in that abscess will be impossible. The immune system and the cells have kind of run to a stalemate. And you have an abscess. The problem with abscesses, they can impinge on other organs. If they're superficial, they're not a medical emergency, although they might look unsightly. Abscesses, the only real way to deal with them is to surgically remove them. If you have orbital cellulitis, the patient should be hospitalized. And IV vancomycin or cefotaxime are indicated. If the patient gets so-called preseptal cellulitis, where you have cellulitis in the face and you get some invasion of the septum, the organisms can degrade the septum. If they degrade the septum, your nose is at risk of falling off your face. Can we agree that's not good? Okay. In cases like that, then you use usually combinations of oral antibiotics. Bactrim is one that you'll use. If they're allergic to Bactrim, use clindamycin. And then you combine that with usually either Augmentin or cefpodoxime. That's for preseptal cellulitis. There yet. Okay, the deepest layers of the skin, if they are infected, you have a condition called a messy blackboard. You have a condition called urocephalus. Spell this right. Classic urocephalus affects the face, but it can also affect the lower limbs. The affected area is swollen, red, very tender, and there will be little blebs of the skin superficially. You have a slightly elevated lesion with very sharply defined borders. It's reddish, and then you'll get streaks, usually of involved lymphatic tissue. That's called lymphangitis. So treatment is with IV cefazolin or ceftriaxone. So initial IV drugs, and then you have the patient leave with a plan to complete a 5 to 14 course of oral antibiotics. And you treat the patient essentially until they're stable. When it comes to folliculitis, I don't know if I said this, furuncles almost never cause any sort of systemic symptoms. Carbuncles might. Depends how big they are. But if they do, it's usually going to be fever. And one of the treatments, because these tend to be open to the hair follicle, you can have people wash with chlorhexidine. Chlorhexidine is available over the counter. You can buy it off Amazon and at Walmart, places like that. Chlorhexidine will kill staph. Putting a hot compress over these two a couple of times a day can draw out material and can shrink them as well. Now, because these affect the dermis, if they're not dealt with, you can get scarring. Again, it depends how big the lesion is. Big carbuncles may need to be surgically drained. They may heal without scarring, but they may scar. It's hard to say. All right, the last lesion, kind of soft tissue infection I want to look at is necrotizing fasciitis. Necrotizing fasciitis. This is caused either by very invasive strains of strep pyogenes or by Clostridium perfringens. Clostridium perfringens, you will maybe remember, causes gas gangrene. This disease usually involves the extremities. This disease can progress very rapidly. It's particularly seen in those with some sort of diabetes or peripheral vascular disease. This disease can advance over hours, causing a systemic toxicity. It can cause loss of the limb. It can even cause death. Jim Henson, the creator of the Muppets, he died essentially from a very aggressive strain of Streptococcus pyogenes that infected a wound and advanced very quickly and took his life. Initially, the skin will be red, but it quickly will develop into patches of red purple with very severe pain and also fever. Also, you'll see this condition called crepitus. Crepitus means that the organism, as it ferments, it makes gas underneath the skin. And when you push on the skin, there's a release of gas. You see this in journals of war surgeons during the Civil War. Gangrene killed more people in the Civil War than bullets did. And pushing on a wound, if the wound creaks and releases gas, that's called crepitus. That's very severe if you see that. Over a few days, the skin will break down, you get bullae that form, and it will become gangrenous over a few days. Diagnosis has to be established with surgical exploration. The necrotic tissue has to be debrided. And then the specimens need to be sent for gram staining culture. These need to be treated very aggressively with powerful broad spectrum antibiotics. You will usually use combinations of antibiotics that inhibit the cell wall plus protein synthesis inhibitors. The protein synthesis inhibitors prevent the synthesis of the toxins that cause this condition. So it'll usually be vancomycin plus clindamycin or something else like that. Of course, the patient's going to need IV fluids because hemodynamic stability will be an issue. They'll need vasopressors as well. Because of the patient might have shock, capillary leak syndrome is an issue. They're going to need albumin. All right, recap. Non-bullous impetigo lesions, the lesions usually start as vesicles or pustules, and they evolve into these gold encrusted plaques. Plaques are usually about 2 centimeters in diameter. They usually affect the face and the extremities. They heal without scarring usually. Bullous impetigo is characterized by painful vesicles and blisters and bullae that can spread rapidly. Topical treatment with antibiotics are used for local infections. You'll need systemic antibiotics for more severe cases. Folliculitis results in discrete, small dome-shaped pustules that involve the hair follicle of either the scalp, extremities, or the buttocks. They improve with topical antibiotic treatment. Cellulitis is infection of the underlying loose connective tissue and adipose tissue. It manifests as an area of edema, warmth, erythema, redness, tenderness, and is barely visible in its lateral margins. Orbital cellulitis affects the contents of the orbits. You get pain with eye movements, drooping of the eyelid, proptosis, and diplopia. Periorbital cellulitis affects the anterior portion of the eyelid. If there's abscesses, they'll need surgical drainage. And treatment with IV or oral antibiotics are used. Erysipelas involves the upper dermis and superficial lymphatics of the face or the lower limbs. The skin in the area is swollen, red, very tender. The margins are sharply defined. That's an important distinction between erysipelas and cellulitis. You'll have an elevated lesion border and streaks of lymphangitis. It's managed with empiric antibiotics. Furuncles are deeper infections of skin follicles. Carbuncles are groups of furuncles. Prevention involves regular bathing, antimicrobial soaps, antibiotics, and then sometimes surgical drainage. And then necrotizing fasciitis is an infection of the deep, soft tissues that results in destruction of the muscle fascia. An overlying subcutaneous fat, most commonly involving the extremities. And the infected area gets red, swollen. Patients usually present with severe pain, fever, and crepitus. You have to have exploratory surgery to properly diagnose it. Surgical debridement is performed with antibiotics and then hemodynamic support. Those are your skin and soft tissue infections. All right, next up are the exanthems, the viral exanthems. Let's take a break. We'll come back and look at the viral exanthems. Oh, and get the case study I sent you, get that out. Oh, great, thank you.
Dr. Baratovich,
Yes.
I'm on Zoom.
Yeah.
Have you moved away from the highlight disease versus skin and soft tissue infection PowerPoint slide?
Yeah, it's not moving.
No.
No, okay. Then let's try this. Okay, does that move?
Yeah.
All right, then let's try. All right, does that move?
No.
No? Okay. Does it move?
No.
Oh, good gravy. Okay, how about now?
No.
No, I don't know what I'm doing wrong. Okay,
Yeah.
okay. I'm not sure what I did differently, but it's okay, it's working now. All right, let's come back to class and think about these viral exanthem diseases. So take a look at the case study I sent you. A 1-year-old boy named Adam is brought to the pediatric clinic by his mother, who is concerned because Adam has a pink skin rash that began in the trunk and is now spread to Adam's extremities. On physical examination, the rash is maculopapular. Maculopapular. Upon further inquiry, the parent recalls that Adam had a high fever. For the past few days, after the rash appeared, and the rash appeared after the fever had subsided. That's an important clue. The rash appeared after the fever had subsided. Also, it went from extremities, from trunk to extremities. That's significant too. Next, you see Rose. Rose is a 9-year-old who comes in with her father. She's a very itchy rash all over her body. Father claims the rash started 2 days ago, after she had a mild fever, and several of Rose's schoolmates have the same rash. Upon physical examination, the rash covers her face, her trunk, and her extremities. There's different types of lesions, some that are papules, some that are vesicles, some with crusts. So both of these patients have some sort of viral exanthem of childhood. This is a group of eruptive skin rashes caused by viral infections. They usually, but not always, but usually affect children. So let's go through these different ones. There's a list of these on your handout. We'll go through them in the order on the slides. First, there is measles, also called rubeola. This is one of the most contagious infectious diseases. It's caused by an RNA virus that's a member of the paramyxoviruses. It's transmitted through respiratory droplets or through contact with a contaminated surface. Incubation period for measles is 10 to 14 days. Then after that, you get a so-called prodromal period. And the prodromal period is about 3 days. The prodromal period is characterized by the 3 C's. Coughing, conjunctivitis, and coryza, or runny nose and runny eyes. In addition, if you look inside the mouth, you'll see red spots with white centers on the oral mucosa. These are called Koplik spots. Yeah. Red raised bumps with white centers. They're in the oral mucosa. Then 1 to 2 days after that, there's a red, blotchy maculopapular rash. It spreads in a cephalocaudal progression, Goes from the head down to the extremities. It spares the palms and the soles of the feet. Spares the palms and the soles of the feet. Remember that. The rash usually fades after 4 days. There might be a cough that lasts another 10 to 14 days. Once you recover from measles, you have lifelong immunity. And the slide here pretty much illustrates that nicely. Now, very often you will go to groups of people, you'll have parents come in, we'll talk about how childhood diseases are not a big deal. They should just let their kid have the disease, they'll be immune, and it won't be any big deal. Most of the time, that's true. But what about complications of measles, which do occur? Complications include pneumonia, encephalitis, and there's severe, and I mean pretty severe diarrhea. This, of course, can lead to dehydration. Because measles infections tend to knock down the immune system. The pneumonia puts you at high risk for a secondary bacterial pneumonia. Because the immune suppression lasts for about 6 weeks, the kids are at increased risk for otitis media. And then some kids who have measles don't completely get rid of it. 7 to 10 years after the initial infection, they get this subtle set of mood changes that eventually evolve into dementia and seizures that, if left untreated, will lead to coma and death. This is called subacute sclerosing panencephalitis. SSPE is not very common, but if it occurs, the child's chance of dying are pretty high. Equally, their chance of permanent disability is very high. Another life-threatening complication is something called giant cell pneumonia. Rare, but life-threatening. Now, if you get the vaccine, you won't have any of these complications, will you? Oh, and by the way, just as an aside, the vaccine is not linked to autism, despite what anyone tells you. If you have a child who is immunosuppressed, vitamin A supplementation can decrease the risk of complications and death if they get measles. All of this becomes completely moot if the kid just gets vaccinated. The vaccine is remarkably effective and extremely safe. Measles diagnosis is usually clinical. There are good serological tests. You look for IgM against the measles virus. Treatment is usually supportive. There are no antivirals to treat measles. Any questions about measles? With pockets of anti-vaccination communities in the United States, you almost always see measles amongst unvaccinated kids. There are outbreaks of it in the United States. It was a disease that at one time was thought to have been eradicated in the US because of the vaccine. Now with the anti-vax movement, measles is coming back. And kids are dying from it, and it's 100% preventable. I don't know about you, but that makes me mad. What kills those kids is ignorance, pure and simple. Rubella, or German measles, is sometimes called the 3-day measles. 3-day measles. This is also caused by an RNA virus that is transmitted primarily through respiratory droplets. This is a toga virus. So it's a different type of RNA virus. This has a 14-day incubation period. Some people may present with flu-like symptoms. This can include a mild fever, joint pain. That joint pain is called arthralgia. That's joint pain. Post-auricular lymphadenopathy. So you'll feel here, you take your fingers and you now go behind the ears. You'll get enlarged lymph nodes, usually with German measles, right there behind the ears. That's post-auricular lymphadenopathy. Yeah, that's a long word. Arthritis that affects some patients, and this is not terribly common in kids, it's more common in adults who get it. You get an arthritis that affects at least 5 joints. Then a few days after, there's a maculopapular rash, like measles. It progresses in a cephalocaudal progression. From the face down the extremities, it too spares the palms and the soles of the feet. The rash clears up after 3 days, hence the term 3-day measles. The big thing about rubella is that it can be transmitted across the placenta to the fetus. Infection, if it occurs during the first trimester of pregnancy, the fetus may develop the so-called congenital rubella syndrome. Congenital rubella syndrome, and this presents with a triad of symptoms. These include deafness, cataracts, and congenital heart defects. That is the triad of symptoms of congenital rubella syndrome. To diagnose rubella, you use PCR or you look for IgM antibodies. No treatment available, but the disease is very, very preventable with the MMR vaccine. Questions about rubella? Fifth disease. This is also called erythema infectosum. This is caused by parvovirus B19. This is a single-stranded DNA virus. Usually transmitted through respiratory droplets. However, this can also be transmitted through blood products. So transfusions can transmit this virus as well. You can also transmit it through the placenta as well. So this one is also transmitted through the placenta. This infection has an incubation period of 4 to 14 days. The virus tends to cause flu-like symptoms. So things like a mild fever, headache, malaise, flu-like symptoms, pretty nondescript. There's hundreds of things that cause symptoms like that. As the flu symptoms start to improve, there's a maculopapular rash that breaks out on both cheeks. And you get what's called a slapped cheeks rash. The slapped cheeks rash. Less frequently, people will get some sort of lacy rash on the body that becomes more prominent after sun or heat exposure. Adults are less likely to present the rash and are more likely to develop arthritis. So adults can get this too, and their presentation is often very different. In most cases, this resolves in a week. The big complication with B19 is that this can infect proerythrocytes in the bone marrow, and it can lead to anemia. B19 can also cross the placenta and infect the fetus. It destroys red blood cells in the fetus. That prevents the ability of the baby's body, baby's blood to carry oxygen. So the heart will start to beat faster. That will cause the vessels to start to leak. You start to get more fluid accumulating in the soft tissue. That is called hydrops fetalis. This puts the baby at great risk for spontaneous abortion or stillbirth. The good news is that if the baby survives, the infection doesn't tend to cause any permanent defects or malformations. You diagnose this with serology looking for IgM, antibodies against the virus. No specific antivirals are available. If anemia becomes a problem, a blood transfusion usually will fix that just fine. So we had fifth disease, now we have sixth disease. So roseola infantum is also called Exanthema subitum. Oh, any questions about fifth disease? No? All right. Went from sixth to sixth disease, also called roseola. Learn how to spell infantum, so called exanthema. Spell it right. Subtum. Okay. This is caused also by DNA virus. In this case, human herpes virus 6. Most common in young children between the ages of 6 months and 2 years. Usually transmitted by saliva and respiratory droplets. Incubation period is 1 to 2 weeks. You usually get a high fever. That fever can be really high. It can exceed 104 degrees Fahrenheit. The fever may last for several days. Because the fever is so high, some kids can experience febrile seizures. So that would be kind of your high yield fact here to remember about these. There's a risk for that. The fever, however, when it resolves, it tends to resolve quite quickly. After the fever is over, the child develops a rose-colored maculopapular rash that starts on the trunk, spreads to the extremities. The rash will usually clear within a few days. So to remember the main features of roseola, here's a mnemonic for you. Fever first, rosy later. Fever first, rosy later. Again, that's as dumb as the rest of my mnemonics, but fever first, rosy later. Diagnosis of this tends to be through clinical features. There is, however, a PCR test available, also serology, looking for IgM antibodies against the virus is available. A lesser known cause of roseola infantum is HHV7. So if the HHV6 PCR test doesn't pick it up, you can also order an HHV7 just to be sure. Treatment is supportive, but if the patient is immunocompromised, there is a drug you can use called ganciclovir. Ganciclovir, most kids won't need it. Talked about impetigo already, talked about cellulitis already, talked about that too. Talked about that. Okay, and here we go now with varicella. Yeah. The type of rash that you get is usually pretty significant. And just the presentation We have a fever, the fever tends to be pretty high, fever tends to resolve quickly, then you get the rash. That's, and the history, also the medical history. That's why I think it's difficult to overestimate the importance of a good medical history. That means asking the right questions and also trying to get the caregiver, parent, whatever, to just try and remember as many details as they can and to convey them as accurately as they can, give you a good picture. And when you guys start doing your clinicals, you'll discover there's an art form to taking a medical history. You have to kind of approach it kind of like this. And you have to learn to ask the right questions because it's easy to be misunderstood. So sometimes you have to ask the same question 2 different ways to try and get an answer that gives you all the information you want. And you have to be patient. You're not dealing with a medical professional. They don't know what you know. You're just trying to coax essentially as many details as you can. And also try to get them to just tell you what happened, to not interpret what happened, because that can color your interpretation. You're trying to be an objective observer. You'd say, look, just tell me what happened. Yeah, I know you read that on the internet. That may be true, but may not be. I'm here to find out if you are right. If not, then I need to make my own choice and also give the doctor enough information so she can make her best diagnosis. Really is an art form. So that's why you get to do it, not me. Okay, varicella. Any more questions about 6th disease, 5th and 6th? Fever first, rosy later. So with varicella, this is caused by varicella zoster virus. This is also a herpes virus. So it's a double-stranded DNA virus. This is a highly contagious airborne virus. It's transmitted from person to person through respiratory droplets when a person sneezes or coughs. It can also be transmitted by direct contact from fluid from the vesicles. Because of that, if you go into crowded or poorly ventilated public spaces like daycare centers or schools, you can pick it up. You can also pick it up from objects like toys or doorknobs or something like that. The virus enters the respiratory tract and infects respiratory mucosa. It starts to replicate. That's the incubation period. Incubation period is 14 to 21 days. The virus then gets picked up by immune cells and gets transported to nearby lymph nodes. It's at this time the individual will usually start to experience the prodromal symptoms of usually a mild fever, headache, and malaise. These are mild in children, they're more severe in adults. So the prodromal period is pretty flu-like. But it's more severe in adults than in kids. So the patient gets an intensely pruritic rash. It itches terribly. Starts on the trunk, spreads to the extremities and the face, covering the entire body, including the scalp. First, you get a maculopapular rash that evolves then into a vesicular rash where vesicles come up in groups or in crops. Within 1 to 2 days, these vesicles will crust over and form scabs. After 5 days, the scabs fall off, typically without scarring, unless the individual picks or scratches them. Then, as some vesicles heal, new ones will pop up. So the big feature of the varicella rash is that you have lesions at different stages. Some are in the vesicular stage, some are in the maculopapular stage, some are in the scabbing stage. You have a mixture. That's a feature you don't see with these other exanthems. Varicella tends to resolve after a week. After that, you have lifelong immunity. However, the organism has the ability to take refuge in neuroganglia, so the dorsal root ganglia in which it might take refuge, it can come out and it can affect a particular dermatome, usually on one side of the body, usually on the dorsum. Starting at the dorsum, wrapping around, you will have the so-called zoster infection, also known as, you use them to put on your roof, shingles. The literature says you're only supposed to see this in older people. You can see this in kids. Kids are getting it too. They usually come out during stress or weakening of the immune system. More nefariously, they can also hide in the trigeminal ganglia. The ophthalmic branch, they can go across the face, they can infect the eye. They infect the eye, they can cause blindness in some cases. That's called herpes zoster ophthalmicus. Darn it, we are out of time. Okay, the dermatophytes and the conjunctivitises, I'm just gonna have to podcast those because we're gonna have to go on. We just don't have time to spend. So chapter 17 for next time, your lab books will be in the office. So pick them up for Mrs. Schaefer when you get back. Have a great Thanksgiving. Please be safe and be well. Michigan leads the nation right now in COVID cases. So please be smart. Come back well, all right? See you guys in 10 days. Blessings on everybody. Hug your family close because they're your family.